Oh, hello. Welcome again. Dr. Anthony Gonzalez with Miami Community Health. We're here again with another important health topic. March is Colon Cancer Awareness Month. Colon cancer and colorectal cancer is the second deadliest cancer in our country, and 1 in 24 people will have colon cancer. So obviously, to bring awareness on what colon cancer is, where it starts, how to screen for it, how to get treated, I brought a friend, a colleague, and a colorectal surgeon, Dr. Joel Calafell, with us today. Welcome, Joel.
How you doing, Dr. Gonzalez? Thank you for having me.
All righty. So before we start talking about colon rectal cancer and what colon cancer is, tell us a little bit about yourself.
So I am a Miami product. I'm born and raised here in Miami, probably 15 minutes down the road, right by West Miami. Went to school here, high school, undergrad. I'm an FIU product, so go Panthers. I'm sorry, I know we're close to the University of Miami. Sorry. Then I went to school and did my training up north in Connecticut, and my goal was always to come back down south and just treat my surrounding community.
Yeah, well, that's great. I have to root for the Panthers because I have a kid that's graduated from FIU. I have another kid in FIU, though I'm a Hurricane, but that's great. So obviously, we're going to focus on colon and rectal cancer, but the first question is, how do people develop colon cancer?
So what colon cancer happens is an abnormal growth in the mucosa of the colon. So it starts off as polyps, okay? These are little abnormal growths. Sometimes it's a buildup of mucosa, but what happens is that in those cells, something happens that a piece of DNA, a protein goes awry, and then it grows and grows and grows, and eventually becomes a tumor, and then it becomes cancer.
So let's first focus on polyps. So you hear that word polyps, and I had polyps removed, and people have colonoscopies and endoscopies. So what is a polyp?
So if you had polyps removed, thank your colorectal surgeon or your GI doctor, because those polyps potentially become cancer. That's why we do colonoscopies. You're screening, but it's also therapeutic, because if we see those tiny little polyps and they're amendable to get them out with the scope, we've treated the potential of that becoming cancer. So that's the importance of getting screened.
And every polyp will eventually become cancer?
Not every polyp will become cancer. We do have ones that are called hyperplastic polyps, where they're just a buildup of mucosa. We take them out because they have no malignant potential, no chance of becoming cancer. The ones we worry about are tubular adenomas, tubular villus adenomas, and serrated adenomas. Okay,
so we are worried about colon cancer, right? And obviously, it all begins with a polyp. How do I know if I have a polyp?
You won't know. Even colon cancer, especially on the right side of the colon, is known as a silent killer. When you start having symptoms, it might be already too late. It might have spread already. And people think that, well, I got a CT scan last year because I fell down, I had a trauma or something, and the CT scan was negative. CT scans are not a good screening tool for colon cancers. When a colon cancer is picked up on a CT scan, it usually means it's very aggressive and it's probably very large.
All right. So then how do I prevent colon cancer?
So really prevent colon cancer is the screening. That's why, we've actually lowered the screening age from 50 to now to 45. And we've done that because when it was initially done to 50 in 2015 and 16, obviously we review all the data and we saw people from 40 to 50 had a double increase in colon cancer and almost double in polyps as well. So that's why we lowered it to 45 if you don't have a family history.
So when you say screening, explain to our viewers, what do you mean by screening?
So screening at the age of 45, your primary care doctor, or if you come see me in the office for another issue, I'm going to screen you. I'm going to talk to you about anybody in your family with colon cancer, grandparents, parents, siblings, and we're going to talk about colonoscopy because that is the screening. And the colonoscopy is a same-day procedure. You come to the hospital, get some sedation. 20, 30 minutes is usually the time of the colonoscopy. If I find a polyp, I take it, send it to the pathologist. We find out what type of polyp it is, the size, and that will kind of tell me when your next screening is. If everything is negative and you have no family history, it's every 10 years.
So then screening means at the age of 45, everybody should be getting a colonoscopy.
Everybody should be getting a colonoscopy at the age of 45. Male, female, doesn't matter what race. Colon cancer is not biased in any way whatsoever.
Now, you did make a mention there, depending on family history, you may need it younger, right?
You do.
So explain a little bit about that for us.
So if you have a family history of colon cancer, and what the United States Health Preventive Task Force mentions family history, it's anybody that's a primary relative under the age of 65 that was diagnosed with colon cancer. So for example, if your dad had colon cancer at, let's say, 55, you should get your colonoscopy at 40. Now, if they're really young, let's say your mom had colon cancer at age 42. You're actually getting your colonoscopy at 32. It's going to be 10 years younger than the youngest person that got diagnosed.
Wow. Incredible.
And that's important to know, because if you're somebody, let's say when you're 50 something years old and you come with me with colon cancer, I do a very holistic approach, not just for the patient, because they're terrified when they hear the words cancer. You got to talk to them about the family. And I say, listen, do you have kids? You need to tell them when they hit 40 or the appropriate age, they need to get screened.
All right. So, and then we're going to move on. So now we have somebody who has a colonoscopy, they had a polyp removed, and then obviously you're going to follow them, right?
Yep.
But if you do a colonoscopy and you find a colon cancer, then what happens?
Then it's a different conversation. And the thing is, I don't wait. If you've been in this field long enough, you know what a tumor looks like. You know what a cancer looks like. If you can't get it out endoscopically, which rarely we can because they're just too big, then what we do is we biopsy it. I mark it with something called, I tattoo your colon, so that way we can see it on the outside. And I have a conversation with the patient right then and there in the recovery room once they're a little bit awake and say, this is what I found. We're going to wait for the biopsies. And if I'm worried about it, I tell them, listen, I'm 99% sure this is a cancer. We're going to start the workup. We're not going to wait 5-6 days for the biopsy. And typically the workup is CT scans, blood work, just to get everything going.
Now, we obviously are picking up a colon cancer with somebody having a colonoscopy, which I guess this is the best way, right? When you find them with screening. But let's say somebody hasn't had the colonoscopy. What signs are there of colon cancer? What are the signs of colon cancer?
So typically, like part of my screening, I tell the patients, any blood, and when you go to the bathroom, a big one is change in stool caliber. Now, not everybody looks at their stool, but I encourage people, you should, if you notice that you used to have, large, bulky stool, and now it's like spaghetti or noodles, that's a concern. There's something there going on that could be constricting your colon, and that's why the stool is coming out in that shape. Another thing is weight loss. Another one is anemia, unexplained anemia, which is a big one for right colon cancer, because what happens is the cancer will just bleed a little bit, and you won't notice, except, you know what, doc? My stool has been a little dark for like the last couple of years, and my PCP always tells me that my hemoglobin is 9, 8, but I never got worked up for it. Lo and behold, it could be the cancer.
Now, you've made a couple comments, and I want to clarify for, obviously as a surgeon, and you're a surgeon, we understand right and everything else. So when you're talking to the viewers and you're explaining to them, a right-sided cancer, and I guess, you're going to compare it to a left-sided cancer, explain to us in simple terms, when you say right-sided cancer, what do you mean, and how is that different than a cancer on the left side?
Yeah, and I get that a lot, and I love to draw. You've seen it, and the patients will tell you, oh yeah, Dr. Calafell's here drawing a picture for me. Wish I had a whiteboard. But what you do is, your colon starts in your right lower quadrant. So if you look at your belly, right towards your right hip, kind of goes up towards your ribs, comes across and goes down. So when I mentioned the right colon, I mentioned also the ascending colon on the right side of your body. And then its left side is on the left side of your body.
And are those cancers different?
They are a little different. Now, the pathology is the same, but their presenting symptoms might be different. Right colon cancers usually cause bleeding and anemia because they really are kind of silent killers, because what goes through your right colon is still kind of liquid. You don't start making stool until you get to like your left colon. And that's where the obstructions, the changes in bowel patterns, that's what comes up on the left side.
All right. So how do we prevent colon cancer?
So that's a good question. Really, preventing colon cancer is the colonoscopy and removing polyps at the appropriate age. But in terms of why we get colon cancer, why do we get polyps to begin with? There's a lot of debate about that. There's a lot of research going into, are we eating too much red meat? Is that the cause of it? A lot of papers out there, but nothing concrete. We do know that a diet healthy in high fiber, vegetables, fruit, and low in red meat, typically where we see countries that have that focus of a diet, their colon cancer rates are typically lower compared to the United States.
Oh, wow. So then let's talk a little bit about the colonoscopy. We're going to get into the surgery, but colonoscopy, very common. A lot of people having colonoscopies. And I always say, like my dad used to quote, the only procedure without a complication is a procedure on somebody else. There are risks with a colonoscopy. What are the risks?
So there are risks, and we tell people these risks, but the risks are very, very rare because people get scared. Somebody has heard, oh, you know what, the grandmother of a friend, they put a hole in their colon when they're doing the colonoscopy. That's a colonoscopic perforation. It's very, very rare. Usually by the book, it's 1 out of 5,000. We're very careful. We try our best not to do it. Knock on wood. Never had one before, but I've seen it in training. Another one that could happen is bleeding. When we take the polyp, it's almost like lassoing, when you go to a rodeo show and they're lassoing a cow. It's a rope, we tie it and we snare the polyp right off and we just suck it through the scope. That area can bleed, and it can bleed to a point where we have to put the scope back in and stop the bleeding, either by burn it or clip it. Again, very rare, one of like 5,000-6,000, especially if you're somebody that's not on all these blood thinners that are out there like aspirin and warfarin. It's very rare.
And then there are alternatives to colonoscopies. I learned that with my mom, who couldn't have a colonoscopy, and they offered her an alternative. And then we see this in commercials all the time. There's commercials all the time for this Cologuard.
Yep.
Is Cologuard the only one? Explain to us what these alternatives are, and are they as good or not?
So I'll go to a brief history because I can go about Cologuard for hours. We need more of a show. So Cologuard, from a colorectal surgeon standpoint, the Association of Colorectal Surgery actually does not value Cologuard as a real good alternative because we really have no long-term data on Cologuard. And the origination of the Cologuard idea was for somebody like you said, like your mom, who couldn't undergo a colonoscopy because there is some anesthesia with colonoscopy. So they developed it like, we can't do a colonoscopy, so we can't for sure know about that they have a colon cancer or a high-grade lesion, but at least it's something, okay? So I tell all the primary care doctors, if they're healthy enough to do a colonoscopy, do the colonoscopy because you can visualize it, cut it, take it out, and you're done. And if the Cologuard is positive, you're getting a colonoscopy anyways.
Anyway. All right. And that's a Cologuard is a virtual colonoscopy, or what is Cologuard?
Cologuard is essentially, it comes in a box. It's a kit. It's a test. So what you do is you give a stool sample, and it's actually 2 tests in one. They're testing for blood, and they're testing for DNA that's secreted by high-grade lesions, high-grade adenomas, or cancers. The problem with that is that it only goes for the DNA of the most common cancer, which is adenocarcinoma. But that's only 70 to 80% of the cancers. There's other cancers in the colon that can show up. And as a colorectal surgeon, I don't want to go after a high-grade adenoma on your colonoscopy. I want to go after it when it's a small adenoma.
Right.
So it's a small polyp, and you get rid of it, and you're done. The other thing with Cologuard is we don't know, should you take it every year? Should you take it every 3 years? And if you're somebody who has a bad episode of hemorrhoids or somebody who's on blood thinners, the test is going to be positive because you're probably going to have blood in your stool just from all your medications. Because when Cologuard comes positive, it doesn't tell you which one is positive. It's just positive or negative. That's it.
And you made an important point and a really interesting point. I get called as a physician all the time. I'm having blood in my stools.
Yep.
And, is it hemorrhoids or do I have a colon cancer? Is there a simple way to kind of educate our community about what is bad blood and what is probably okay blood? Or is all blood, that you see on your toilet paper, in the toilet, is that all bad stuff?
Usually if somebody comes to me with rectal bleeding, even though they have big hemorrhoids, my first question, have you ever had a colonoscopy? If the answer is no, I'm going to screen you because rectal bleeding is a common symptom of a possible high-grade adenoma or possibly a colon or rectal cancer. Now, if you're like a 22-year-old person with no family history and I can obviously see a hemorrhoid or a fissure, then it's a conversation. But if I treat the hemorrhoid, I treat the pathology, and you're still having bleeding, I'm going to push you towards colonoscopy.
So that's not something that anybody at their house can make a decision on, like, if I'm bleeding with toilet paper and my stools are brown, it's still,
I go talk to your doctor.
Okay.
Really, rectal bleeding, blood out of your bottom is not a normal thing.
Dr. Google doesn't work in colorectal cancer either, no?
I fight with Dr. Google every day. I'm sure you do too.
All righty. So let's get down to the meat of this. Now, obviously, the patient's gone through screening. Patients had the colonoscopy. We've gone through the patients that have had their polyps removed, and you've cured those patients. But God forbid, on some day, you find a cancer on a patient and you biopsy it. Now, obviously, the patient's going to need surgery. Everybody with colon cancer needs surgery?
Everybody with colon cancer that's treatable needs surgery. So we do CT scans before surgery, not just to see if there's anything else going on, but to see if you have a spread. Because if you have a spread to the liver or the lungs, which are the 2 most common sites, then the discussion happens. If the cancer is not obstructing you or causing a lot of bleeding to the point that's making you symptomatic, we actually treat those patients with chemotherapy first. Because for most cancers, especially in the abdomen, the primary cancer is not the thing that kills you. It's the metastatic disease, the spread to the liver, the spread to the lung. That's what actually kills patients.
All right. So then let's say you do the CAT scan on this patient and they just have a lesion, whether it be in the right colon or the left colon, and they need surgery. Okay. Now, what are the fearful things people always say? You're going to operate on my intestine. Everybody needs a bag, right? Correct. Everybody's going to need a bag to do poop on the outside. And obviously that's not the case. So explain to us a little bit about how colon surgery works.
So how colon surgery works is all depends on where the tumor is. If it's on the right side, we're taking out your right colon. If it's on the left side, we're taking out your left colon. And people think like, well, if the tumor is only like 2 centimeters, why am I taking out a foot of colon or half a foot of colon? Well, the reason why is that the colon has a very specific blood flow. And when I take out a colon cancer, I want to give the pathologist lymph nodes, which all travel along the blood vessels of that part of the colon, because that changes the stage. Stage 2 colon cancer is a cancer that kind of stays in the colon. Stage 3 has invaded the lymph nodes, and that typically needs postoperative chemotherapy to better your chances of survival. And it's been proven, stage 3 colon cancer, you get chemotherapy, your survival benefit, your 5-year survival all go up dramatically.
And do patients need bags after colon cancer?
That's a good question. Patients are always scared. Even patients that get diagnosed with colon cancer in maybe another country, we have it here. This is we're a big international population. They're scared to see a surgeon because they know the answer. Oh, I'm going to need a bag. That's not necessarily true. And it's actually kind of rare nowadays with our technology and our understanding of creating connections with the colon and the small intestines. Typically the only people that are getting, ostomy bags are typically low rectal cancers. The reason why is that when we make that connection is a very high risk area of leaking. So that's why we bring up a diverting loop ileostomy, which is only for about 6 to 8 weeks. Now, if somebody comes in to the ED with horrible pain and they have a cancer they didn't know about that's causing an obstruction, at that time, it's an emergent surgery. You're going to end up with an ostomy bag. However, most of the time it is temporary, barring that it's not a stage 4 cancer.
And obviously, when you have emergency surgery, you can't prepare for it. So
Correct.
How is the preparation for colon cancer surgery? Because the patient has to prepare themselves.
Correct. Yeah, we want to clean out the colon as best we can. So actually, it's the same prep that I give for colonoscopies, plus a couple of oral antibiotics, because we want to clean the colon of stool and also bad bacteria. Okay, we want to make it as close to a sterile environment as possible, because we know when we make a connection, it's not just about the tension and the blood flow to that connected piece, but also we know about that microbiome, the bacteria in the intestines, that if the bacterium is too aggressive or virulent was what we call it, it can break down your connection.
Wow. And so let's talk a little bit about nowadays in the technology and advancement of colon and rectal cancer surgery. How is that done? What is the surgery like? How long does the patient stay in the hospital? So what do we usually inform patients about?
So what we tell them is that I try to give them a little history lesson. I love history, especially surgical history.
So give us a history lesson.
I'm happy to. So back in the old days, you were diagnosed with colon cancer. You're getting a big giant incision midline, or sometimes a side incision called a Coker incision, and you're going to be in the hospital for anywhere from 7 to 10 days, because obviously you're going to be in a lot of pain because it's a big incision, multiple complications from that, hernias, infections. It's a more difficult surgery to recover from. Nowadays, with laparoscopic advancement and robotic advancement, it's 3 to 5 small holes, maybe a slightly larger hole to take the specimen out. And most hospitals with our, enhanced recovery program, 2 to 4 days in the hospital. And I tell the patients, you're probably going to be back to 100% in about 1 month.
Wow. And so talk about that enhanced recovery. I know I love it, and we use it as well. We use it obviously in colon surgery, which it was pioneered in colon surgery and orthopedic surgery, and we use it as well in bariatric surgery. But explain, since you mentioned it's a good opportunity to explain to our viewers and our listeners, what is an enhanced recovery protocol?
And it is. It doesn't even happen post-operatively, and it happens pre-op too, where we're giving patients, we're not starving the patient for 2 or 3 days before surgery. We actually give them like a high glucose drink the morning of surgery, so that way their glucose imbalance during surgery is actually very well balanced. We're giving them preoperative medication that's not narcotic based to try to lessen the pain after surgery, and then after surgery we try to avoid the narcotics as much as possible. Especially in colon surgery, one of the key steps that we want to know if you're ready to go home is, are your intestines working? And opioids and narcotics all slow down your intestines, so we try as much to give you a non-narcotic program. So a lot of Tylenol, Celebrex, Robaxin, which is a muscle relaxer, all really have shown to enhance the patients that they get back home safely.
Wow. And so we're dealing with the colon. The colon has bacteria in it. You have tried to sterilize the colon, but you can't sterilize the colon, right? And infection is a concern. So how does a patient prevent infection after colon surgery?
The key thing is, everybody's a little different with high-risk patients. Patients that are very obese and diabetic, those are high-risk patients for not just infection on the inside, but also on the outside on the skin, because their immune system is a little weaker. So, we tell the patients after surgery, listen, if you're diabetic, we really got to get your sugar under control. If you're a smoker, I tell them, listen, stop smoking 2 weeks before and stop smoking 1 to 2 months after, because that all inhibits wound healing and puts you at risk for infection. And the most fearful thing we worry about is infection that comes from a connection leak. That's actually the most dangerous part of the surgery, is that if your connection leaks, we have to reoperate, and then you're at higher chance of a bag.
Yeah, and so that's something that I struggle a lot in talking to patients and explaining to them because when you're at the time of surgery, you guys check that connection
Everything, yep.
to make sure it's airtight. So talk to the viewers about how you guys check that connection, and then let's say 2-3 days later, that connection there's a little tiny opening in it.
Yep.
How does that happen? What do you guys do in surgery to make sure it's perfect? But then later on, it doesn't. It's not.
And with robotics, you even have another step to check it because in robotic, we have something called ICG, which is a special dye that we give to the patients, and it lights up your blood vessels. So we can actually see the connection point. Wow, it's all green. That's the color that it gives. It looks great. And then what we do for lower surgeries, I actually will do a small version of a colonoscopy when I'm doing a left colectomy to check the anastomosis. I see with my eyes, I fill it up with air, we submerge it underwater and make sure there's no bubbles. So it's airtight, it's watertight, everything, but there's still a chance of a leak. And what happens is that, maybe a small area of that connection is not getting enough blood flow, and over time it opens up, it breaks down. The bacteria goes haywire and kind of, doesn't let the mucosa to heal, and it leaves a gap and it makes a hole in your anastomosis. And I tell the patients, listen, we do everything possible, but I tell them, best surgeon, best surgery, best patient, depending on the part of the colon, it's a 1 to 3% chance of a leak, 1 to 4% if you're talking about the rectum.
And it's not the end of the world if you have a leak, right? That's treated and you will survive and you overcome it, right?
It's treated. Does it increase your morbidity and your recovery and your stay in the hospital? It does, but it does put you at higher chance of an ostomy bag. But, the key thing, if it's a cancer surgery, the cancer is out, hopefully depending on the pathology. But the key is now we have this issue and we have to fix it. But it's not, if you leak, you're going to have a mortality. It's very rare nowadays that we have mortalities from leaks.
All right, so we've gone through colonoscopy, we've gone through screening, we learned a little bit about polyps as well. We've talked about colon rectal surgery and the advancements of laparoscopy. We talked about robotic surgery, enhanced recovery. Now, somebody, you take out their colon, whether it be right or left, they recover, they go home. What is the treatment like afterwards? What is the follow-up like afterwards?
So typically I see all my patients 2 weeks out. So just to check how they're doing. Are they eating? They're going to the bathroom okay? They're walking around. They're feeling good. And typically if it's a laparoscopic robotic, most patients are actually doing pretty good. They feel pretty well recovered. I always, you probably do too. You see them walking in like, okay, how are they walking? They okay? They have their car keys. Oh, they drove here. They're good. So typically the recovery for cancer and the surveillance, we call it surveillance, all depends on the stage. So usually by the time the post-op visit happens, I have the pathology. I know what stage of cancer it is. If it's a stage 1 or 2, typically it's observation and surveillance is all you need. And typically you follow up with the oncologist to get better educated about that. But usually it's repeat CT scans every 6 months for the first 2 years. And it's a colonoscopy with me in 1 year after the surgery to make sure that connection is good, because we're also looking for regrowth, okay, or recurrence of the cancer. And if it's going to recur anywhere locally, it's going to be at the connection. So typically we do colonoscopies 1, 3, and 5 years after your surgery.
And you continue, right? Because they're at risk of having colon cancer again, right?
Yep.
I mean, you could have a brand new, you could take out the left colon and they can get a cancer in the right colon.
Correct. Yep.
So you follow them basically forever. Okay. Yeah. And then what about chemotherapy, radiation, maybe, I don't know, immunotherapy? Talk to us about all those other therapies. Okay. Is that necessary?
So if it's stage 3 or higher, and even now we're doing research at high grade stage 2s, there is a survival benefit for chemotherapy. In colon cancer, chemotherapy is the typical postoperative treatment if you have a stage 3 or stage 4 cancer. For rectal cancer is almost kind of separate than colon cancer because sometimes we give preoperative chemo and radiation to try to shrink the tumor at the time of surgery. For colon surgery specifically, or in colon cancer, very, very rare we give radiation. Unless at the time of surgery, we see the cancer is involving the abdominal wall. Obviously, we can't take out your abdominal wall. So you'll need radiation to that area. But if it's not, typically it's chemotherapy. There's no radiation needed.
Wow. And then you already mentioned the treatment is not only to the patient, it's the family, right? Yeah. So again, you have to identify the family members. Siblings are important? Siblings are important and kids are important.
Yep.
Wow. Yeah. Incredible.
So I tell all my cancer patients, do you have mom, dad, brother, sister, kids? And, they'll tell me, oh yeah, I have an older brother. Call him now. Tell him to get a colonoscopy like yesterday.
Wow.
So I tell them very urgently, it's a serious thing. Now that you have somebody in the family with colon cancer, you got to get everybody screened appropriately because, this is preventable. Let's say, that 55-year-old patient has a 45-year-old sister. I do a colonoscopy. Hey, there is a good sized polyp in the right colon. I take it out. That cancer never grows.
You just saved her life.
Saved her life. Saved her a big surgery.
Wow. So obviously what we're trying to do here is create awareness for colon and rectal cancer awareness, because it's such a deadly cancer. And this is what we're focusing on in March. And we've covered that, surveillance, which is colonoscopy, screening, what you call screening, is so important in preventing it. We learned a little bit about colon cancer and how it begins with a polyp. Anything else you think our viewers need to know as you're trying, as a colorectal surgeon here with our group at Baptist Health, anything else that you want to create awareness and people need to know and take home with them in regard to, colon and rectal cancer?
The biggest thing is, check your family, learn, become a historian, talk to members in your family. You never know what, grandma or grandpa will tell you. You never know. Same thing with siblings, and just be aware. And if you are at that age, you need to go talk to your primary care doctor and get you an appointment with either myself or one of my colleagues or one of my gastroenterology colleagues that do colonoscopies as well, and get you screened appropriately. The other thing as well is tell your friends and tell everybody, because there is a big stigma of colonoscopies.
Yeah, there is.
People don't
want to have them.
Yeah, they don't want to have it. They're scared. Oh, the prep is terrible. I tell people my prep is Gatorade and Miralax. Like it can't be any easier. Like if you like orange Gatorade, I'm gonna give you a liter of orange Gatorade with Miralax. That's my prep.
Wow.
I don't use Go Lightly. I don't use some of the nasty preps that are out there because I know patients don't take them. Plus, one of my old attendings made me try Go Lightly for the first time. Yeah, I felt so bad as a man. I've given Go Lightly to 300 people. It's like, yep, yes, you have.
Yeah. No, but nowadays I had mine. I don't know, like about a year or 2 years ago, and the prep is starts within a couple of hours.
Yeah.
Like you started at 2 a.m. or 3 a.m, and they gave me this thing, and I just took it twice, and of course it was, I didn't sleep at all because you're getting cleaned out. But yeah, I started at a young age, and I think that you're exactly right. That comment about the stigmata of colonoscopies, and that definitely will prevent colon and rectal cancer.
It will. Well, and the other thing too, I always tell my patients and people out there is that, colon health is really important. And, what keeps your colon clean? Fiber and water. I tell people all the time, especially in the United States and all developed countries, we have a huge issue where we just don't eat enough fiber. And people don't have a good education on where can I get fiber? You have all these diets that are out there, keto and, Atkins, carbs are the enemy. Whole grain bread has probably a third of your fiber requirement right there.
Wow.
So people stay away from it. Same thing, keto diet, no carbs. Fruit has carbs. Fruit has fiber. People think, I eat 3 bags of spinach a day. You turn that big Costco spinach bag around, 2 grams of fiber for the whole bag.
Wow.
So it's actually the crunchy vegetables and fruits that you want to go after, the whole grain breads. And that is all healthy for your colon. Water is huge for your colon. Your colon's main job is to reabsorb water. And your colon doesn't know if you're low on water or not. It's just going to keep reabsorbing water. If you don't have a lot of fluids in your system, that's where, the stool dries out, the constipation comes in, hemorrhoids comes in. And we really think that poor colon health is a kind of a catalyst for these polyps to grow.
Wow. And we haven't even talked about diverticular disease.
Yeah.
Which is, I'm gonna have to bring you back and talk about.
Exactly.
That is that's caused by chronic constipation,
Yes,
right?
Yes,
wow. So obviously, again, Dr. Anthony Gonzalez, we're trying to bring awareness on colon and rectal cancer for March. Get your colonoscopy, do your prep, see Dr. Calafell, one of our colleagues in our group, your local gastroenterologist if you're visiting us from elsewhere. And be aware, talk to your friends, talk to your family. I think it's the prevention that's more important. But obviously, if you are diagnosed with a cancer, you seek out care by a colorectal surgeon to get the appropriate care. So thanks, Joel, for coming.
No problem.
Thank you for educating our community. And once again, Dr. Anthony Gonzalez here with Miami Community Health, reminding you to be healthy, be safe out there, and take care